Well, let's talk a little bit about the joint structure of the knee joint. And in particular, we're going to focus on the 3 degrees of freedom that the knee has. I know we generally think about the knee as a hinge type joint, which is going to primarily focus on the flexion and the extension aspect, which is where the chief amount of motion comes from. But there is, to a smaller extent, a little bit of medial and lateral rotation. This is particularly pronounced in 90 degrees of flexion. At neutral or full extension for the knee, there's very little medial and lateral rotation. And then also there is a little bit of ab and adduction, or you may refer to this as a valgus and varus force at the knee. And there are some ligaments that are going to control this. However, this is not necessarily an active motion that we typically perform at the knee, whereas flexion and extension, there's a lot of prime movers for that. And then medial and lateral rotation, there's some movement with that controlled by the hamstrings and some other muscles that we'll go over. Now in terms of the alignment, so looking at how the bones lay out from a static or a stationary position, we're going to be looking here. So if you were to draw a line directly from the femoroacetabular joint, the hip joint, and draw that completely down to the floor, what would you notice? Let me zoom in on this a little bit. And so you could see that our femur is not directly lined up exactly with that. So you can see there's a little bit of an angle here. So if you remember before, this is the angle of inclination. And this contributes to the amount of angulation or ab and adduction of the femur relative to the femoral condyles, or relative to the tibia. But you can see you have this alignment right here. So if this was completely straight, that would be at 180, but because you have this position right there, we have a small amount, I'll show you on the other knee, we have a small amount of valgus positioning naturally at our knees. Most of the time this is estimated at around 5 degrees. The Newman textbook has this listed at a range of 5 to 10 degrees. So that's important to consider as we look at some different angles within the hip and knee joint combined. Now something that changes when you look at it going from a static position, such as in standing, to a dynamic position, is that the load and the force changes. So you can see in a static position, as you're just standing in bilateral stance, the force, let me get my marker out here, you can see the force is going to go up relatively equally through the lateral and the medial aspect of the knee, as it's going to culminate at the source where you have the femoroacetabular joint. Now what happens in unilateral stance? So we're walking or running or going up and down a step, and you can see how this is shifted. So even though the weight comes up here, because it's veering off and it's actually going more towards the center of the mass, where S2 will be located, it increases on the medial aspect and decreases relative to bilateral stance on the lateral aspect. So that's generally going to cause more loading on which side of the knee, would you think, medial or lateral? Yes, on the medial side of the knee, which is why you might develop more arthritis and more degeneration of the medial meniscus as opposed to the lateral meniscus. And what if someone had a more valgus position of the knee to start with? So naturally their knee was more valgus in position as opposed to varus. How might that affect this? So if the knee was in a more valgus position, So I drew a little bit more of valgus knee alignment. You can see that this is altered slightly, so you could see there might be a little bit more of the load that's being transferred there, and then there's definitely some more potential to have load absorbed differently at the hip, especially the femoral neck, which might be a concern. So it does alter this slightly. However, it's going to depend on the individual mechanics, and for that to be analyzed to really determine what ultimately is going to happen with that individual. And then we do have two terms that are typically going to be related to how this static positioning is going to occur. You have genu valgum, which sometimes gets nicknamed knock knee, so that you have more of a valgus type positioning. And this is where the angle is greater than that 185 degrees. So if 180, or just completely vertical, such as these two blue lines, is it the femur more lateral to that, the proximal femur more lateral to that as opposed to the distal femur. And if that were the case, how would this shift or change the compressive forces? Which compartment of the knee would that be forced primarily towards, the lateral or the medial compartment? Yes, so there you go. So that's going to force things slightly over to the lateral compartment because of the line of force, especially in a bilateral stance position. With dynamic walking and other activities, there could be alterations or compensation, so it's a little harder to say in those scenarios, but in a bilateral stance, it's definitely going to be shifted more laterally. Alright, you made it this far, so let's bring out a little cheesy joke time. This one's a cool one about skeletons. Why don't skeletons go trick-or-treating? Give up. Because they don't have any body to go with them. Okay, that's good. Moving on. We'll get cheesy joke man out of here. So let's continue talking about genu valgum. And this one is really focusing on the other influences of genu valgum. So in order to get a genu valgum at the knee there, it really could come from contributions from either angle. So if you have a coxa vara at the hip, that may contribute that. So that would be an angulation of where the femoral head goes into the acetabulum as opposed to the relationship with the femoral shaft. Or, you notice down here, if you had an increased pronation, which would, let me get my drawer out here, which would basically, here we go, which would kind of put the foot downward in this direction, so it would drop the medial aspect of the foot. That would consequently drop the medial aspect of the tibia. And then at the knee, that's going to basically cause this kind of positioning. That would contribute to a genu valgum as well. So there's just some other things to think about with that. Could be contributions from the hip or ankle, or a genu valgum at the knee could promote excessive pronation at the foot, so it can go in either direction with that.